אוקיי. היי וערב טוב לכולכם שהצטרפתם אלינו. אני הילה וייס, מייסדת שותפה ומנכ"לית של עמותת אגם. אנחנו ערב בלייב וובינר השלישי בסדרת הלייבים שלנו לרגל חודש המודעות ל-EDS. הוובינר של היום יעסוק בפיזיותרפיה מותאמת לאהלרס-דנלוס ולגמישות יתר, וכבר איתנו כאן נמצאים ניקי פרנקלין ותום ליבנה. ניקי היא פיזיותרפיסטית מוסמכת לטיפול בבעיות שריר שלד, עם ניסיון של מעל 15 שנה בתחום. היא מתמחה בפיזיותרפיה בתחומי המחול, אומנויות הבמה והפקת קול, ובפיזיותרפיה ל-EDS ובעיות גמישות יתר כמובן. ניקי גרה באנגליה, במידלנדס, והיא מטפלת שם בקליניקה שמשותפת לה ולבן הזוג שלה קירן, וגם אונליין. ויחד עם ניקי נמצא איתנו חבר הקהילה שלנו, תום ליבנה, שהוא בעצם זברה מהגרת שחי באנגליה, ונמצא בטיפול אצל ניקי. והוא האמת הולך תכף לפתוח את הוובינר של היום עם הסיפור האישי שלו, בהגעה גם להבחנה וגם לטיפול פיזיותרפיה מותאם לתסמונת. אחריו נשמע מניקי, ויהיה לנו אפילו גם תרגול קצר שתוכלו להתנסות בו. אנחנו תכף נעבור לשפה האנגלית, ונחליף שפות. לפני כן אני אזכיר שכרגיל הלייב מוקלט, והוא יעלה לספריית הסרטונים בפייסבוק שלנו, וגם לערוץ היוטיוב שלנו בשלב מאוחר יותר, ואתם שצופים בנו דרך הממשק של הלייב, מוזמנים לשאול שאלות בתגובות, ובסוף הוובינר יהיה לנו סשן שאלות ותשובות. Okay, אז אנחנו עוברים לאנגלית. So hi everyone, and a very happy Ehlers-Danlos and Hypermobility Awareness Month. I'm Hila Weiss, I'm co-founder and CEO of Agam, the Israeli nonprofit for EDS awareness. We're super happy to be here for our third live webinar in our special May webinar series, and tonight's live will be about physiotherapy for people who live with EDS or hypermobility spectrum disorders. We're hosting Nikki Franklin and Tom Liebne, which will both be sharing their expertise and experience. Nikki Franklin is a specialist musculoskeletal physiotherapist with over 15 years experience in her field. Her background lies heavily in dance, voice, and performance physiotherapy, as well as training those with EDS and hypermobility. She has her own private practice with her husband Kieran in the Midlands in the UK and online. And Tom Liebne here is our dear community member living in England and seeing Nikki for physiotherapy sessions. So Tom and Nikki, I want to thank you both a lot for being here with us today, this evening, and we will shortly begin with you, Tom, with your personal experience, and then later on we'll have Nikki and a short live exercise for us all to get the feel of it. Before we begin, I'll just remind our viewers that the webinar is being recorded and it's going to be uploaded to our social media and our YouTube channel, and that everyone watching can ask Tom and Nikki questions in the comments, and we'll have a Q&A session at the end. So Tom, the mic is yours. Super happy and excited to have you guys here. So to you.
Thank you so much for having us. I do apologize in advance, everyone, for speaking English and not in Hebrew. It's just we decided it's going to be a little bit confusing for me, and I guess maybe for other people as well, just to switch between Hebrew and English all the time. So I'm just going to be speaking English, but later on in the Q&A, you can ask questions in Hebrew, and obviously I can answer in either language. It's fine. So thanks for having me. I've been a member of the Zebra community on Facebook for a while now. I think many of you kind of recognize my name, so now you can attach my face to it, and I do apologize just in advance if I get stuck or anything. So my story with hypermobility is a funny one because I generally didn't know that I was hypermobile. Growing up, I had always been struggling with certain symptoms, mostly around GI stuff, but never something that was so, apparent or was so very debilitating or disabling in any way. So I wasn't really aware of being hypermobile myself. I did have some hypermobile friends who normally had some subluxations and dislocations of several joints and stuff. So in my mind, they were hypermobile and I was just a normal person who was maybe slightly flexible or slightly too bendy, but nothing too serious. So my story essentially begins after I moved to London for the first time in 2017. I was an opera singer before I actually started studying science, as most of you probably know. And I met with a British teacher here and I started working with her. And there was this one time when we worked and I had started to feeling a bit of like pain in my neck, in my throat actually. And I thought it was like an inflammation or something like that. So I went to an ENT specialist and he checked and was like, no, everything's fine. Your problem is just a strained muscle. I was like, how do you mean a strained muscle? It's not like one of those neck stuff, you know, that you normally get when you've got like issues with your neck and shoulders and stuff like that. It was literally in my throat. And he referred me to see Nikki. So I went to see Nikki and she treated me and did a kind of interesting treatment, I should say, called voice physiotherapy, like manipulation on my throat. And Nikki will probably explain that later on, how it works and what it does. It was extremely painful, but very helpful. And she was like, did you know you were extremely hypermobile? I was like, what, hypermobile? Yeah, I mean, I guess I kind of know it, but whatever. And I started seeing Nikki regularly, week after week after week, for treatments and for some Pilates, because it was suggested to me that this should help with my singing and my posture and also not to strain the voice as much. And little by little, she started telling me, oh, did you know that thing that you told me you're suffering from, that is also kind of connected and related to hypermobility as well? I was like, oh yeah, okay. And it just went on for a while until I finally realized, okay, maybe everything is related to my hypermobility. And then we started working around that, you know, just strengthening my body, making sure that I don't strain my voice too much, and that I know and understand how to use it properly. And I think I got an actual diagnosis from a rheumatologist. I think it was after COVID started, because then I wasn't able to see Nikki regularly, and things started deteriorating. I wasn't going out as much. I wasn't as active as normally. And I started having all these weird symptoms. So I used to get nauseated after meals, and I used to sit down and my head started spinning. I used to get DOMS out of the most mundane tasks of like opening the door or holding my phone and scrolling up and down. And it got like a real problem. So I asked Nikki, what should I do? Do you know if there's like a doctor I should see, if there's something that I could take to kind of relieve the pain and just make things better? And she suggested I should see Dr. John Althwaite, which if any of you manage to see him, I highly recommend. He's an extremely professional and very, very patient doctor who suggested a sort of kind of treatment plan for me, and things just started improving gradually. I've been seeing Nikki regularly via Zoom, essentially, and been working out regularly, and things are on the mend. So, Nikki, would you like to tell us a bit about why it works? Like, why does this Pilates kind of help us to manage the symptoms and all of that?
Happily, of course.
If I can just interrupt for a second and say that at this stage already, people are probably super intrigued and really wanting to know how hypermobility has to do with voice function. And of course, very curious to know, Tom, how you managed to actually improve that. So if you can elaborate a bit, and Nikki also in your following answer. Thanks, sorry, thanks.
Of course, no, sorry. So essentially, we all know that hypermobility is very abundant in joints. And the voice is actually, the voice box, the larynx, is actually a joint in itself. So it's held up by muscles, which Nikki will later explain it better than I do, because she knows the anatomy far better than I do. But essentially, I knew that I was hypermobile because of the things I was able to do with my voice. So the voice is made out of these two straps of ligaments called the vocal folds or the vocal cords, and they come together when you make a sound, and they stretch as you go high in pitch, and they kind of shrink when you go down in pitch. This is like generally how it works. It's a bit more complicated than that, but that's generally how it works. So when I went to the voice doctor, to the ENT specialist essentially, and he looked in my throat, he was like, okay, make a very high note. And I was like, do you have a preference? Like, do you want to play a note? So I would repeat it, and he was like, no, just the highest note that pops in your mind. And I just did. And I opened my mouth, and my jaw is also very hypermobile. So I opened like this kind of mouth. And I just belted out the highest note that I could possibly do. And the lamps were shaking and his stools were shaking. And I was like, you know, getting into it. But what you could see, which was actually quite interesting to see, is that my tiny little vocal folds could extend really, really, really far, essentially. So both he and I was quite shocked because I didn't know that I was able to do that. I didn't really know how my voice functions. And normally singers don't really go into this kind of information, they just want to sing. But that was like an interesting revelation. And again, as I said earlier, it's like my story had a lot of small hints to my hypermobility, which I was kind of repressing because to me it wasn't such a big deal. I didn't really experience many symptoms apart from that. And stretching the voice so much over and over again, I didn't realize was the reason for all this pain that I was having in my jaw, in my neck, in my throat, because everything is essentially connected. So if you strain one muscle, the other side kind of has to compensate, generally. So when you overdo something, when you overstrain a muscle or overstretch a joint, there's always like a certain feedback, a bodily feedback that you get with extra contraction, essentially. I hope this makes sense.
Sure, great, thanks.
Okay, so I can build on what Tom's just been telling us there with the voice side of things, but I think just like with any body part, you have to look at the body as a whole, and that's what's really important in a hypermobile body in particular. So just to go back slightly, I worked in London for about 15 years and a little bit in Germany with Cats the Musical as a resident physio prior to that. So my work has always been very heavily linked to the performing arts. But as a result of that, you see a lot of hypermobile bodies because I'd say possibly more than 90% of those that perform to a high level, be it sport, athletics or dance, will have some level of hypermobility because it allows them to do what they do quite well. It creates nice lines, nice amount of flexibility, and particularly with the dance crowd, that looks very aesthetic on stage. So there's a lot you can do with a hypermobile body, but understanding how that works and the requirements that that body needs to be able to stay strong, stay mobile, keep doing what it wants to do well, whether that is on stage or just in life, is really important. And I think, like Tom touched on, a lot of people that are hypermobile don't always get that kind of clear-cut diagnosis from the get-go. It's sometimes a bit of an evolving thing over years where you get a little bit of feedback from a few clinicians along the way, or you pick up things and you read things yourself. And I know a lot of my clients that do have hypermobility don't really get a proper diagnosis until much, much later in their adult life, which can be quite tricky because they sort of then look back and think, well, that's why I really struggled with this at school, or other things throughout their childhood that just got missed. And so if we start with the body as a whole, and then I'll home in on the voice stuff a little bit more, the reason the hypermobile body can be tricky is because the collagen that your body is made up of is just different. It's more lax, it's more mobile. And often people just think that is to do with the joints, the bones, the ligaments, the kind of musculoskeletal stuff. But as Tom said already, you know, he had some GI stuff. A lot of our clients experience digestive issues alongside their hypermobility, and that's because the collagen of the entire system is different, and that includes your organs, your skin, your eyes, your brain, not just the bendy joints that people perhaps initially think of with a hypermobile body. So you're going to get an impact on the whole system, and it's not always one size fits all with that. You'll get grading scales of some people that only really get a bit of joint laxity, but you'll get other people that get heavy digestive issues because their gut is a little bit more lax. Some people don't get any digestive issues. So I think that's also hard for the individual dealing with it, because not everyone is exactly the same in terms of what their symptoms are, but also it can be tricky for clinicians that don't know enough about a hypermobile body to fully understand how that's impacting an individual on a whole sense. So from a physio point of view, there's a lot that we can do to help the hypermobile body move forwards and manage with whatever it wants to do in life, whether that's just kind of looking after your children, whether you want to be sporty at the weekend and in the week, if you want to do other things that are a bit more physically demanding with your body. And the reason that we can help with that is because we can really help with getting you strong and kind of helping guide strength management. But you've got a little bit of an uphill battle, and I say that to all my hypermobile clients, and that's because of going back to that collagen and the sort of substance that your body type is made up of. It is harder to strengthen. It can take a little bit longer to strengthen, and even if you do, you're still up against it slightly, because those tissues, if you think about, if you've got a muscle, let's talk about the bicep. So you've got your kind of contractile muscle belly in the middle of the muscle. Now that muscle attaches onto bone by tendons at either end. So when you strengthen a muscle, you're working on that contractile muscle belly, the middle bit of the muscle, and that can get stronger. If you've got a very bendy body that's made up of different collagen, that contractile belly is going to take a little bit longer to get strong. But then even if you do work really hard at that strength, it's still attached to tendons, which you can't necessarily strengthen. You're strengthening the contractile belly. It's attached to tendons that are even more lax than other tissue types in other bodies. So you've got to work even harder at the strength stuff to kind of counter the fact that that muscle is strapped to your bones and ligaments by more bendy tissue than other people have to contend with. So it's a little bit of an uphill battle, but it isn't impossible. You just sometimes need a little bit of help and guidance along the way. The other things you need to think about is kind of recovery, healing timeframes, pain episodes, and injury and pacing, because tissues that are made of a different substance can be a little bit more susceptible to injury. They can be a little bit more susceptible to injuries taking a slightly longer healing process to get over. And they also, you can find that fatigue is has a fair place in building strength. So you've got to pace the activities to be able to have recovery days to then go again and work on strengthening. Now, the reason Tom has benefited from the strength side of things in relation to his voice is because whenever we treat a voice patient in clinic, we have to look at their whole body, whether they're hypermobile or not, because there are many different anatomical features of the body that link the rest of the body to the larynx. So as Tom has already said, this is a really simplistic explanation, but probably the best one to kind of, without going too heavy in anatomy and pathophysiology. The larynx, which your voice box, is a joint suspended by muscles, and how those muscles behave will have an impact on how those vocal folds that Tom was talking about come together. And as those vocal folds come together, that's what creates sound. So if there is something influencing those muscles, it's going to influence the voice by influencing the mobility in that joint and how those vocal folds are coming together. So, for example, if you carry a lot of tension around the musculature around the larynx, it can make the mobility more restricted, and it can make it harder work to bring your vocal folds together. Now, in a hypermobile body, as Tom said, he's got quite a lot of mobility to play with there. You know, he can really stretch those folds. He can get some notes that will shatter your windows. Now, but what can happen, the body then tries to stabilize that amount of mobility from somewhere. So muscles can get tight, and it's sort of counterproductive to what, for example, Tom is trying to do with his immense range. So we, as a physio, want to identify areas of why is the voice misbehaving? Why is it not doing what you want it to do? And we'll assess the musculature and the mobility in that joint as part of the picture. But then we also look at the entire body, because especially kind of upper back, shoulder girdle, postural muscular tension can have a huge impact on how these muscles behave. There is a muscle that attaches into the side of the larynx that literally attaches onto the front of your shoulder blade, which is the bony bit at the back. So if you find that you carry tension in your shoulders, those muscles that attach directly into your shoulders, but also into your larynx, is going to have an impact on how that joint can move. And if that joint's not moving freely, you're not going to get the sound production that you want. And this doesn't have to be just for singers. This can be people that speak on Zoom all day, have to present, primary school teachers, barristers, people that have to speak more than most for a living. And when things become tight or restricted, they often come into clinic complaining of either, as Tom said, pain when they're using the voice, discomfort, maybe a feeling of a lump in their throat, or a loss of range. So whereas Tom gets his high notes quite nicely when things are nice and free, when things become tight, you notice a loss of range, in particular the upper register. Their voice cutting out, generally feeling pretty fatigued after having using the voice, quite achy, quite tired, feeling like they need to rest their voice for a couple of days after using it for a prolonged period. So as physios, then we'll want to strip back some of that muscular tension, mobilize the joint to get the vocal folds moving freely, but also for the more long-term management, look at those postural changes. If there are any underlying, work on any muscle tension in the upper back and shoulder girdle, with a combination of manual therapy and also some targeted exercise prescription, which often falls in quite a Pilates kind of stance. And that would be for a hypermobile body or anyone contending with voice problems. The reason we see a bit of a pattern in kind of postural tension and voice in our hypermobile client base is because of that level of mobility in your entire system. What you tend to find is people grip and hold tension in areas of the body to try and support it in some way possible, but it might not always be where we want you to be supporting from. So a real common place for people with hypermobility to get quite tense is kind of over the top of the shoulders. And as someone that's trying to work on their voice, tension in this area is going to be counterproductive to nice free vocal production. So there's a lot of work that we can do in freeing up the larynx locally, but also in freeing up the posture through some hands-on work and some postural exercise prescription going forward. And that's true for all kind of hypermobile MSK presentations as well. By MSK, I mean musculoskeletal presentations. What we tend to find in a very mobile body is areas of tension that can build up, which is also can be confusing for an individual if they're not sure that they're hypermobile. So they'll come in for treatments and say, for example, they're coming in for back pain and you do a few tests and you say, oh, did you know you've got a little bit of underlying hypermobility? And they almost don't believe you because they feel really stiff and they can't even touch their toes. And that's a real common one for people with hypermobility. You know, they've got lots of excessive range in other directions, but perhaps the hamstrings have got really, really tight or their back's feeling really tight because there are episodes of muscular spasm and muscular restriction and muscles overworking to try and stabilize that body from somewhere. But like I said, it's not always the areas of the body that we want to be doing all of that support work. So it's good to kind of get that assessment and see where else we could perhaps put a little bit more, bring some more strength to the table from other areas to allow those areas of tension to simmer down. There's a need for physio going forward, I feel, in a hypermobile body because it's something that's, your tissue type isn't going to change. That's you, and that's okay. But what I always say to my hypermobile bodies is, it's not a curse. It's just that you've got a little bit more homework to do to maintain the goods, to make things feel a little bit easier. Because you are going to have episodes of pain along the way. There are going to be episodes of spasm. There will be joint sprains, muscle sprains and ligament strains, and instabilities. I don't know what levels of mobility we have in this talk today, but some of you may find that you have dislocations, subluxations regularly. Some of you may not quite have so much of that yourselves. So there is a slight uphill battle, but it's not impossible to try and get the body a little bit more comfortable and moving forward. So we can help reduce your pain, we can help improve strength, and deal with the challenges along the way, such as the fatigue and that cyclical nature of that. So a lot of our clients with hypermobility sort of feel like they're chasing pain around their body sometimes because something gets sore and stiff, and it doesn't really make them want to do any exercise because it feels sore and stiff. So then their mood also gets a little bit lower, and that becomes a bit of a cyclical cycle, really, because it's very hard to get out of that without the right guidance and right support to kind of show you these are the exercises that you could start doing. They're safe to do. They hopefully shouldn't be too irritable. And then you incrementally build it up from there. So our treatment approach with our hypermobile clients tends to be a combination of the hands-on treatment, and that is true for the voice stuff, but also for other areas of the body, to reduce kind of a bit of muscle spasm, make things feel a little bit more comfortable. And then very much on the exercise prescription front to help get that body stronger in a way that it's going to help sustain it going forward. And there's many, many benefits from exercising in a hypermobile body. It can calm down the central nervous system, can release muscular tension. You're going to get that increase in serotonin, which is going to lift any mood-related issues. You're going to promote muscle tone and therefore joint stability by surrounding those joints with muscles that are stronger. You also increase your sensory and proprioceptive awareness, and that all of that combined can then reduce your risk of injuries or re-injuries. And you'll also get a better understanding of your own body by going through this and knowing that when you get little niggles or aches and pains, there is things that you can do to help get that moving again, which is quite important when you're living with something that it makes you feel a little bit different at times and a little bit misunderstood, or that you're a little bit alone and being passed from pillar to post with clinicians that perhaps don't know what they're doing. So anything that can give you your own kind of sense of control over your body is going to be a positive thing going forward. And as I said, there's many athletes, many dancers and high level performing folk that do have hypermobility. Granted, they'll probably have a team of people around them helping pace their activities, choose their strength and conditioning work and work with them. So for example, people in the Royal Ballet will have physios that screen them for their hypermobility, understand those that do have the more extreme end of hypermobility, and they will help them, if they've got a big show at the end of the week, that there's a lot of rehearsal schedules planned towards the end of that week, they'll have to work with the strength and conditioning coaches and the rehearsal teams to plan, okay, when do they go full out in these rehearsals so that they don't get to the end of the week and they're completely fatigued out and can't do the actual performance that's required of them. And it just takes a little bit of planning to make sure that their tissue health gets the recovery that's required, fatigue doesn't become an issue, and any injuries along the way get the adequate recovery timeframes. But even if you're not a professional dancer or athlete, those things are true, and pacing with a hypermobile body is extremely key. You don't always need to go flat out and do high impact activity, but just think more of a little and often approach to keep the body moving, keep the joints and the muscles a little bit more supple where they need it, and to provide strength and support where that is required too. So as sort of Tom said as well, a large part of his kind of exercise rehab has been down a Pilates route. It's a nice way to give modifications and options for exercise that focus on postural control, core stability, and a little bit of mobility where needed. Then once you sort of get those down, you can start to add in load, resistance, and build from there. So, Tom, we're getting to a point where we're adding little hand weights now, resistance bands, and you're led by the client. Everybody is different. And just because Tom's now added weight to his workout doesn't mean that everybody else needs to. It's very individual, and that's how we tend to work in clinic, to provide a treatment approach and an exercise program that suits the individual's needs. And again, that comes back to the fact that people with EDS and hypermobility have such varying levels of symptoms, and even along the way, you can have periods of time where, like Tom said, you had to reach out to a rheumatologist because things were getting quite bad. But you come out of that, and it can do that a little bit throughout the journey as well, and various external factors can impact that along the way.
There's another thing, Nikki, which I'm experiencing, and I'm sure other people experience themselves, being hypermobile. Yes, generally you've got the areas where you feel hypermobile and you generally have more hypermobility rather than other parts of the body. And you've got your general set of symptoms that you can experience, but also every time I see you, I come with a different set of symptoms in a sense, because I could get certain muscles tight on one day that the next day wouldn't be a problem anymore, but other wills. So it's kind of a very changing,
evolving.
Yeah, it's an evolving thing, and I reckon a constant challenge for the physiotherapist, isn't it?
Yeah, it is. It is if you don't know what you're dealing with as well. So I know I get a lot of frustrated clients that have come, and this isn't a dig at the national health system. This is more just people not necessarily understanding a hypermobile condition well enough. And I get some clients that have come from a national health physio that because they've been referred for neck pain, for example, but they are hypermobile. So actually by the time they've been seen by that physiotherapist of waiting time frames, it's actually not their neck anymore. It's a bit more mid-back or lower back. And that's exactly what Tom's saying. It's a bit evolving. You sometimes feel like you're chasing pain or spasms around the body. And that's because hypermobility is all-encompassing. And sometimes you might have sat for longer at your office desk with a sustained posture that has tightened one area up, but the next day that's fine and you're moving on to something else. So I think when we look at the exercise prescription, yes, we can target it towards what's perhaps going on the day, but we've always got to try and think, let's get the whole body moving well, let's get you optimized so that your baseline head to toe is as strong and as stable as it can be, so then the little day-to-day external factors that can influence this may not knock it out of balance as much as it perhaps could without the exercise. But I'm also super aware that that it can feel a little overwhelming on where to start, especially if you're feeling a bit rubbish or you're in pain. So it's nice to have the support of a clinician that understands perhaps how to pitch it and where to pitch it, and then how to progress it when you're ready. And we've got a section that we're going to go through in a moment with some little practical mobility type stability exercises that are pretty appropriate for all bodies, but I've tried to give a couple of options because I know I have some clients that arrive in a wheelchair because of their hypermobility. And then I have some clients that are ready to go on stage and start a performing arts career. So there's different ways of pitching the exercises. There's always a way to modify something. And it's about working with a clinician that's able to help you find that way and kind of get you moving in a way that suits your body. So I think, Tom, maybe we should, anything you want to add on to that?
Yeah. Generally, I just want to add that I'm a living proof that it works. Honestly, I got to such a very dark place just a few months ago because of after I had the second jab to the vaccine, to the COVID vaccine, my body reacted really, really weird, I must say. And then it just kind of ignited this thing where I had a very massive flare-up with brain fog and just joint pain and stiffness, and it was horrible. But seeing Nikki weekly, like religiously, twice a week, and doing the exercises and doing walks and endurance exercises as well as strength, and just working on everything as a whole, it works. Just a few weeks after that, I was an entirely new person. And today, I mean, I got the jab in September, and today is May. Yes, it's May. And I can say that I'm completely out of the woods. I mean, there's no memory of that horrible experience. And it's thanks to this holistic approach of just treating everything together and pushing through. I mean, it takes a while, right? It takes a while to work, but generally after a few weeks, you start to feel that kind of improvement. And then it just, for me at least, my body is very reactive to physical exercise. So hopefully it will help you as well.
And the only other thing that I would add to that is it's not just about finding a good physical therapist. So as Tom had to, when things got a little bit more tricky for him, being referred to a good network of clinicians, it'd be wrong for me to say it's just me, the physio, that can fix this. It's not that. You need a good little team approach for when things kick off a little bit more. So having someone that can manage the exercise and the physiotherapy stance is one thing, but when pain or some of the more not so obvious hypermobile symptoms start coming into the mix, the brain fog, the extreme fatigue, you do want to kind of maybe be under a rheumatologist in particular that understands hypermobiles and can sort of be the overseer of the management plan. If medication needs to feature, they can prescribe that. They can help guide the physiotherapist on certain areas. If they've had to do any scans or they've found anything on any scan findings, they can keep the physiotherapist in the loop so they know what's going on from a structural point of view, as well as anything else. You know, they can talk to you about a bit of the nutrition side or point you in the right direction to help with that as well. So I think it's about having your team and who you can call upon at certain times. But I guess from a physio stance, if we can optimize your baseline level with getting mobility, stability, and strength in the right areas, your body will be a bit better for it going forward. So we were going to, sorry, Tom, you okay?
Yeah, sorry. I just wanted to say that I think this is one of the biggest problems for members of the community living in Israel. It's not just that you don't really have a lot of professionals knowing about these syndromes, both hypermobility and EDS, but also don't really know how to treat these people, and I mean us. And like in generally, this is one of the biggest challenges that members of the community kind of face. So I think it's just good that you've mentioned that if you stick to the plan and you strengthen your body, you can just get through, and then you can kind of just figure out things as you go along. Like I know for me, this is generally what I was doing. Like even with Dr. Outhwaite, it's not that I'm seeing him regularly, you know, for checkups, and the only thing that I'm actually doing regularly is physio. It's Pilates, it's strengthening the body. And then if something kind of goes awry, then I know I have people to turn to. So I think generally this is a good strategy. I mean, it works for me, it might work for other people as well. So just have those specialists in hand, like a list of specialists in hand. Maybe this is something that the charity could do, or I don't know, maybe we could do that together in the group and just come up with like a list of professionals.
Directory, yeah.
Yeah, just people we can turn to whenever things go kind of wobbly. So do you want us to do the live exercises?
Yeah, so what I thought we'd do, I mean, I don't know if anyone listening to this is in a position and wants to move right now, but if you've been listening to me talk for a little while, you might feel like you need to move right now. So what we've done, and what Tom and his partner have very kindly done, is linked it together because my IT skills are not able to do this. But I pre-recorded some exercises with modifications, which I hope will be appropriate for whoever's listening. I've tried to do a combination of a few exercises that are just nice day-to-day ones to do. So if you think about moving your body little and often, mobilizing the spine, getting it moving, adding a little bit of glute and core stability into the mix, but very gentle. So none of this is going to sort of floor anyone. They should feel relatively easy to do, and you don't even have to do them all in one go. You could sort of pick and choose throughout your day. If you've got a static job, some of them are quite nice to do throughout the day so that you don't have that kind of impact of a prolonged static posture on the body, which can make things a bit uncomfortable. But you'll see from the videos there's options for whether you are able to get onto the floor, whether you need to do them in a chair, or whether you need to do them in standing. So Tom will probably play the video now. So if everyone who does want to participate wants to find a little space for them to do some movement, and then I'll try and talk over the videos with some prompts and cues for people that want to do it now, or perhaps want to watch this back and have a go at a later time.
Great. So Tom, go ahead and share.
Okay, so we're going to start with some cat-cow options, I believe. So if you're able to get onto the floor, you want to get onto your hands and knees with your hands under your shoulders, your knees under your hips. You drop the head, you lift the spine up to the ceiling like a cat, and then you turtleneck the head through, pull the shoulders back away from your ears, maybe 8 to 10 times, just gently mobilizing through the back and getting a little bit of mobility through there. Remember to breathe. Option 2, if you're in a seat, really similar. You're still going to round the back like a cat, pushing your arms forward and the spine away, and then press your hands onto the front of the knees to open the chest in the opposite direction. So you're still thinking of that same kind of cat-cow movement, but you're in your chair and working in a seated position. And then from here, lifting the spine, shoulders back and down. Option 3, in standing. So if you don't want to get onto the floor, but you want a little bit more than a seated position, place your hands on your knees and same sort of movement, drop the head, tuck your tailbone under, lift your spine to the ceiling like a cat, and then reverse it, come through with a little turtleneck, actively pull your shoulders away from your ears so that it's a little bit active as well as a mobility exercise. Then we have some thoracic rotations to try and get that mid, back and shoulder girdle moving. Really nice for our singers, this one too. So on all fours, you can thread your arm through and then open it back out to the ceiling. Sort of 5 times on each side might feel enough. Again, not forcing into any episodes of pain, just working gently with what feels good to you. And think of almost like wringing your spine out like a towel as you twist it one way and then the other. You can also do this in your chair, just crossing one hand over the opposite knee and rotating around, twisting from that mid, back and rib cage. Remember to breathe, don't hold your breath. And doing that a few times either side can feel quite nice, especially if you're sat at an office desk or working for a while. And then we've got some pelvic tilts and bridges, really good for trying to activate some deeper abdominal stability and some glute stability. So lying on your back, you can rock the pelvis back and forth a few times and then start to take it into this full bridge where you tuck the tailbone under. Think of lifting your tailbone up first and articulating through each bit of the spine, bone by bone, lifting about fist height off the floor, then peeling that spine back down bone by bone. So the tailbone is the first thing you lift up, but it will be the last thing that comes back down. Imagine your spine as a string of pearls and you're lifting them up one at a time and then putting them back down one at a time. You can also try this in sitting. So you're just lifting that spine and then tucking the tailbone under, just really mobilizing through that lower part of the back. And as you tuck under, you'll get a little bit of lower, deep abdominal contraction as well. This one's a nice little stretch for the neck. Good for our singers, good for people carrying neck and shoulder tension. You anchor the collarbone down, you take your ear to the opposite side and then rotate to the same side. Hold for about 20 to 30 seconds and then try the other side. So anchor your collarbone, take the ear across and rotate to the side that you're stretching. This is a nice jaw exercise for some of our vocal clients that have got stiffer with what they're contending with. So this is a little jaw protraction and depression exercise. So lying on your back, you glide the lower half of your jaw, so your chin, up towards the ceiling. Keeping that stretch, you open the mouth, and then keeping that stretch, you close and relax back down. Maybe 10 times, morning and evening. That can be a nice one to keep a little bit of jaw mobility on the go if things have stiffened up. There's some details for where you can find me. And if anyone wants anything going through again or has any questions, I'm happy to answer. Oh, actually, I think Tom's got a little voice exercise for you all as well before we go on to that.
Yes, I do. So just a quick mention, because I don't think that we did earlier. The thing about the voice, which I find interesting, is because that everything is interconnected, the voice muscles aren't just, and organs actually, are not just involved in voice production. They're also involved with breathing, with chewing, with swallowing, yeah, all of these things. It's the same machinery that does all of that. So if you've got problems with your voice, it will probably also reflect in the way you breathe, if you breathe through the mouth like I do, or when you eat and try to swallow, when you drink and stuff like that. So one of the things that I find very beneficial is I use this device, which is essentially like a very big straw with a very wide kind of opening. It's made of silicone, which is medical grade silicone. It's a really good one. I'll add the link later on in the recording, so you could all just order it from Amazon. You put it in a bottle and you just fill in I'd say about 5 centimeters, 6 centimeters of water. And what you do, you put your mouth on it and you make some bubbles. At first you just let your air out, so I'll just show you how it works, like this. Just to make sure that you got how it works properly. Now, after you figure this out and you manage how to blow bubbles without the bubbles flowing in your, coming back into your face, you can start making sounds. And I would suggest, normally when we speak Hebrew, our larynx tend to be very, very high and very, very tense. We tend to speak very, very like this and really, really force our voices out. What this does, it helps us work with our breath. It teaches the muscles the right kind of air pressure below the larynx, below the vocal folds, and it strengthens the muscles that stabilize the larynx. So you don't overstrain it, essentially. So what I suggest you do is when you start voicing into this tube, you start with a very, very low pitch, and you kind of imagine as if you have like a boiled potato in your throat. That's the kind of imagery that voice teachers use normally. So you make kind of a huh kind of sound, like a very, very deep sound, and straight into the tube. You probably can't hear it, but like that. Then you can go on and do whatever vocalize that you like. You can go up and down, up and down. I'll also add a link to a video series with a lot of exercises that you can do. And what it does, as I said, it works essentially like resistance bands that we use in Pilates, but for your voice. And the benefits are phenomenal. I can say for myself that whenever there's a time when I speak a lot of Hebrew and don't sing as much, this is my lifesaver, essentially, because it lets all the tension go. It kind of strengthens the muscles where they need to be, the larynx where it needs to be, the tongue, the root of the tongue gets out of the way, and you can just breathe. So that's me. Shall we move on to Q&A?
Yeah, and first of all, I want to say a huge thank you to you both, Nikki and Tom. I think this was super enlightening. And just I'm so happy that this webinar too stresses all like the basic principles of working in physiotherapy or physical treatment whatsoever with EDS. The fact that it's a whole body work, like you said, and it's not just like stabilizing my elbow, because like you said, the elbow attaches to tons of other organs, and how everything evolves and changes and needs maintenance, and the fact that we need a clinician that knows us and learns with us is so highly important. And of course, we still struggle with finding those clinicians, therapists or doctors, but talks like this, I hope, are steps in the way to change that. So there are a few questions. I'm going to start at the end. There are 2 questions here about the device you just showed, Tom. 3 actually. Anat and Yuval are asking, how do you manage that tube if it's great for your voice, but it's really, it really hurts your jaw, and Yuval asks, it really hurts your head. And another one, 3 in a row, is the tube and bottle exercise okay if you have POTS? So maybe that's, you both can decide how to answer that.
Let's start with the last question about POTS. I would say take it at your own pace. Generally, there shouldn't be a problem using this kind of tube with POTS, but that being said, if you feel like you've got like, I don't know, symptoms and you feel like you're about to faint or anything like that, you know, the regular POTS stuff, just stop. Do it just little by little.
And the same with, I mean, I think that's very true for any kind of exercise prescription for any, whether it's for the voice or for any body part, because the way that this can present in different bodies is so individual. You've got to be led by your own irritability. And that's why it's nice to work with a vocal coach or a Pilates instructor or a physio that understands what's going on. So when they add something into the mix as part of your new regime, there's a follow-up, there's feedback, you're reporting back as to how you're feeling as you change the exercise, and just be led by your own personal symptoms, as Tom said.
Yeah. Absolutely. Sorry, what were the previous questions?
The previous were, what do you do if it's
pain.
really hurtful for your head and jaw?
Okay, so I'm struggling with my jaw quite a lot. My jaw is very, very hypermobile. I mean, you probably can't see it from the way I speak that much because I'm practicing.
Like an anaconda.
Yeah. It does open up like an anaconda, for real, like not even joking. So, so I've been struggling with it quite a lot, and every time I overstretch my jaw, I get spasms around here and around my neck and my shoulder. And these also project onto my face, obviously, because this is where your facial nerve starts, essentially. So what I suggest and what I do in order to avoid this kind of pain, when you use the vocal tube, you make sure that your lips are actually the ones holding the tube. So you don't put any pressure from the jaw, so you don't hold it with your teeth like that, which puts strains on the jaw. You just kind of gently hold it with your lips. If you feel like you're experiencing some sort of pain, maybe you're using too much water. The water is supplying the resistance here. So I suggest put even less water or hold it slightly higher so you would feel less resistance and see how it goes. Generally, just take it by your own pace. When I started working with these vocal tubes, it wasn't an easy path. And because of my tendency for the root of my tongue to just press down on the larynx, I used to be kind of hoarse after I used the vocal tubes. I was very, very tired. But a few days into this training, I was already an entirely different person. So pain sometimes, I know we tend to kind of fear pain, but pain sometimes is good. Pain sometimes suggests that we do something right, that we strain the right muscles, that we develop the right muscles, and it guides the way.
Yeah, I think this is our kind of golden path to find which pain is bad and which pain is good.
Yeah.
A question for you, Nikki. Efrat asks us how to breathe right while talking and while singing.
Yeah, the breathing, there's many schools of thoughts on this. So different vocal coaches may also say different things depending on whether you're more a classically trained singer, whether you're a musical theatre singer. For me, you need to be able to provide a little bit of support from the kind of deeper low abdominals, but maybe without too much external musculature gripping, because the issue when everything starts to try and support you is you get a lot of forced air production, which can then be a little bit brutal on the vocal folds. If you're forcing a lot of air, that can be a bit traumatic to the vocal folds. Your muscles then around the larynx are going to want to tighten up to prevent that hefty airflow coming through, and then you get counterproduction of nice free voice mobility because everything's tightened up because you're forcing a lot of air. This tightens up, and it's a bit of a bad cycle for the voice. So there are ways of kind of learning more of a Pilates style breathing technique, which is more about kind of recruiting deeper low core abdominals on an exhale and just gently switching things on, very pelvic floor orientated, but also learning to let go completely as well. So what I find in my dance population that also sing, they get quite punchy in their abdominals and almost like overwork things and because they're so taught from an early age to pull in, pull up, don't let your belly stick out. When they then try and sing, that's actually quite a lot of hard work because they're not able to get that nice big breath expansion and fully let things go before they take another breath to sing again. So it very much depends on what type of singing you're doing, what school of thought you come from a breathing point of view. From a physio stance, I think just teaching that kind of Pilates breath in life with exercise, walking around, sitting at your desk and moving forwards with that side of thing is how I tend to teach it. So if anyone wants to do a little bit of a pelvic floor exercise while we're sat here, I can give you some good prompts and cues to try and help where to recruit when you're taking a breath. So if everybody places their hands on their tummy and takes a really nice big breath in and lets the belly expand into the hands on that inhale. But then as you exhale, you're going to, in this order, and I apologize if my cues do not translate particularly well. Imagine as you breathe out, you are picking up a diamond with your back passage. Ladies, if you've got a front passage, through your front passage, and then pulling your navel in towards your spine. So it's like a back to front drawing in of that deeper low pelvic floor level on the exhale. It's a bit like trying to pat your head and rub your stomach at the same time. If you've not done this kind of breath before, it's a little bit odd. So you take a big breath in, belly expands, everything's relaxed. As you exhale, you contract your back passage, your front passage, and then gently pull the skin off your hands in towards your spine. And you hold that there until you take your next breath in and you let it all go. Belly expands back into the hands. And then as you exhale again, switch it on from back to front, navel to spine at the end. And it's gentle and it's small, and it's probably 70% less than what everyone's just done. It's not about turn it all on and hope for the best. It's small, it's subtle. And actually, once you get to a point where you're able to switch it on and release it, you should be able to maybe just switch it on and then sustain conversation for a little bit without, it's something to practice. And but it's worth kind of knowing how to do, because it does form a lot of some of the Pilates exercises that you can do to be able to really encourage kind of lower abdominal recruitment. It's very good postpartum for people that have had children, to learn how to recruit the body, the muscles for the body in that order, in that area, as well as for supporting breath control and to a certain extent some of the singing stuff after that.
I just add that when you sing, breath is kind of a part of the musical phrase, essentially. So you want to make a thing out of it, but also make sure that it helps you reset for the next sentence, okay, for the next musical phrase that you're about to sing. So for me, when I breathe, when I'm singing, I just make sure, obviously, I incorporate everything Nikki just said, because I found it extremely helpful, but also I try to make like a mental note of where my larynx is, because if you notice it, when you breathe deeply, you let go of your larynx. It just kind of falls and it sets in a lower position, which is generally healthier and just helps you produce a better sound. Obviously, if you want to produce a certain like belting sound or like a more scratchy sound, then you do other things that I have absolutely no knowledge of. But generally, breathing just helps you set the tone for the next movement.
I think you just touched on a really good point there as well, Tom, about getting that larynx in a nice lower resting position before you sing. So for any of our singers, when we treat the voice and we want to release tension, we're trying to optimize the resting state of the larynx, which when things are tight tends to get high and restrictive, and then that makes it hard to get the vocal fold closure that you need, and you have to work much harder. So when we treat around the larynx, we're trying to bring that resting state of the larynx back down. You sometimes even hear it in their voice straight away. You hear them talk and they talk a bit lower afterwards, but then that gives them the room to play with. So for you to then get your top notes, Tom, your larynx has to go up there. It's not that we don't want it to travel and get high ever, but it's that having that nice optimized base position that you just spoke about before you then go there, that gives you the flexibility to do the vocal gymnastics that you want to do. And similarly for people that are belting, you're obviously going to go for a slightly different vocal fold closure pattern, but essentially if you're in a nice resting baseline position, it's going to be easier for you to achieve that afterwards. So yeah, getting that larynx kind of down and free, and then doing what you want to do with it is key.
Great, thanks. I think we keep going back to the point of the need to stabilize, be it a shoulder or your larynx or your vocal cords, which is our main thing to learn. So another question is, some of us get when we struggle with these kinds of vocal problems with all types of diagnoses, like voice cord dysfunction, voice cord paralysis, and like Tom mentioned, the breathing and swallowing and everything like is related. So should people with hypermobility, or let's say, how should people with hypermobility try and make sense of what causes what, and what type of kind of differential diagnosis should they be asking for? And again, not enough clinicians here or in this level of knowledge, but still, how would you suggest, Nikki?
So for me personally, so if, for example, you came to me and you were complaining of vocal difficulty, a loss of voice or cutting out or anything when you were doing your online Zoom sessions, so I would assess you from an objective point of view, have a feel on where your larynx is resting, have a look at the surrounding musculature, have a look at your posture and how you seem to be voicing. And if it's purely a musculoskeletal related issue, so things have got tight, there's a bit of postural stuff going on, we can get on top of that quite quickly in a couple of hands-on sessions from the way I treat as a physio for the voice. But because it's the type of thing that if it is purely muscular, you'll hear a difference in their voice pretty much straight after you've treated them. So if I'm not getting that good change in a couple of hands-on sessions, I'm already thinking I need to be writing a letter to either your GP or referring you to a private ENT if you don't want to go down in where I'm at, the NHS route, to get an ENT. So my first port of call would be an ENT review to just have a look at the vocal fold integrity. They'll be able to see if there's any signs of acid reflux. They'll be able to see exactly what the vocal folds are doing because they'll put a camera down there to see. They'll get you to vocalize while the camera's there. So when you're making different sounds, they can see exactly how those vocal folds are behaving. Is there any pre-nodular swelling? Is there any nodule or polyp there that needs to be addressed? Is there an asymmetry, a vocal fold paralysis, as you've said? So I would say, if you can't get in to see a physio who understands the voice and can treat a hypermobile and the voice, you probably want to, an obvious one would be an ENT review, as Tom's had. And although it didn't give him loads of information, it did show him how mobile things were in there to some extent. But at least it screened him for nothing sinister on his vocal folds, because as a physio, I don't want to sit on that. If someone's not seeing improvement in a couple of sessions with me, I'm suspicious there's something a bit more pathology-wise going on. And that's where I would want an ENT to have a good look as well.
And would you say it also goes like the other way around? If all tests come back normal and like the ENT is, I don't know, then and you know you are hypermobile already, yes, then it's probably musculoskeletal.
Probably musculoskeletal, but the other thing that we can't ignore, which is a big part of the voice work that we do, is I work very closely with speech and language therapists and vocal coaches and singing teachers. So there's a technical element to how people are producing voice as well, which can then have a knock-on on the musculoskeletal side of things. So again, it's a real team approach. So I'm very lucky that we found a nice network of clinicians that work closely with ENTs that we work with here, but also can guide other elements of the vocal rehab. So whereas I can strip the muscles, I can mobilize the larynx, I can guide some of the exercise, you do sometimes want someone who features with either a bit of speech and language technical support or a singing teacher or a vocal coach that can do that, depending on what the goal is.
Mm-hmm. Yeah.
I can only say from my own experience that I moved a lot of teachers along the way, and it's only after I consulted with Nikki, because at some point I was so unhappy with my voice training because I kept going sore, essentially. I kept losing my voice after voice lessons, which is the one thing that should ignite all your alarm bells, so she suggested I should see this one voice teacher, which I'm now seeing quite regularly, who works with this in mind. Like he himself slightly hypermobile, and he knows exactly what he's doing, so I could recommend on him as well. I will add his details later on to the recording in the comment section. And the voice is just another organ, if you will. Like if we train the muscles of the shoulders and stuff to stabilize them, but then behaviorally we keep doing this, then eventually this is what's going to stick. It's not just about the strength. So this is what the training is about, especially with voice, because it's not an organ that you can see. You can only hear the outcomes of usage. So if there's a recurring problem that you can't solve with a doctor or a physiotherapist, maybe look at different teachers who can teach you different technique.
Yeah, I think this is a very important message that we know, that we experience. If someone doesn't help you, you need to find someone who will, which of course is a challenge. I think we have a last question about the tongue. Efrat asks, how should the tongue be positioned so it doesn't press your voice box? I hope voice box is like understandable.
I think what's asking is what should we do with the tongue so that it doesn't put extra tension in the larynx, maybe.
I think
so. The tongue is quite interlinked to a few areas, because if there's tongue tension, there can be laryngeal tension, but also if there's tongue tension, there can be jaw tension. If there's jaw tension, there can then be larynx tension. So it's another one of those where that knocks onto that can knock onto that, and it's a little bit like what comes first, the chicken or the egg, that's caused what tension. If you have been told by a vocal coach or someone that you're working with that you hold tongue tension, there are certainly little exercises and things that you can do to help mobilize that. But having someone assess you and maybe to see if actually is your tongue tension coming from your jaw or is it coming from something else can be very useful. So then the exercise in the little sequence that we played at the end, that jaw mobility exercise, can indirectly help your tongue tension and your larynx tension. I also sometimes get clients to do a little bit of tongue root massage themselves if they feel they're holding tension there. So to do that, I tend to get them to put the tip of their tongue behind their bottom teeth. And you can add a little gentle stretch to that, as Tom is demonstrating really nicely there. And using maybe a little bit of massage cream or some moisturizer so that you don't friction burn yourself. You're working, I don't know if you can see what I'm doing here, it's a funny angle, on the soft tissues underneath the tongue root here, quite firmly for a couple of minutes. Now you do have glands that can come up under here. So if you feel a little ball or a little hard lump, don't give it grief. I have some clients that say, oh, I found this lump, so I really massaged it and it made it a bit sore. They're your glands, leave those alone. They can fluctuate depending on how well you are. Stick to the soft tissue and you can do some nice tongue root massage, which can be beneficial going forward. And I think you want freedom in it. It's not something that you want to, like your jaw, you don't want to be holding it at night or during the day. And similarly, you don't want the tongue to be putting excessive pressure behind your teeth all the time or up on the roof of your mouth all the time. You just want freedom there. So some of those little mobility tricks and self-massage techniques can be very useful to help that, but also getting someone else's eyes on it to see, okay, why is the tongue getting tight? Is that a technical thing? Is that a surrounding musculoskeletal thing? Will also be beneficial.
From a technical perspective, from voice usage perspective, you also need to train how to voice without the tongue. So it's one thing for that's what I found in my training. Like I could massage the tongue and it would help me relax. But if I'm not training how to voice without my tongue, when I start singing, I immediately pick up all that tension immediately.
Have you got a pen in front of your tongue? Or like a skinny object? Yeah, I mean, I don't know if you want to do this on camera, but there is a nice exercise you can do where you try and hold the pen with your tongue, usually a slimmer pen, really. So that would have been a bit, like a skinny straw, a little cocktail straw. You put that on your lip, you stick your tongue right out over it to hold that in place, and then try and do some singing or siren up and down the scale whilst holding that item in place with your tongue, because then if you're trying to use your tongue too much, you're going to try and pull back and the item will fall out. But if you know, like you just said about trying to dissociate the tongue from vocalizing, that's quite a nice exercise to do.
Yeah, so no, I'm not going to put it in my mouth.
That's fine, I understand.
But yeah, I mean, if you just take your tongue out and you sing with your tongue out for a little bit, you kind of sense in your throat the right position and how you vocalize without it. And this was helpful for me. Also with the vocal tubes, you kind of get it built in.
Great. Wow, super fascinating. I mean, we entered this microcosmos of hypermobility in your voice area, but I think it has a lot to do with what we usually want to stress, which is not only how to reduce subluxing or dislocating, but also how to be more aware of our muscle and how we use them and how they cooperate with each other, which is super important. Okay, guys, I want to thank you a lot again, and I see some thank yous here in the comments. I really appreciate this time, and I'm sure and I'm very hopeful we have some clinicians watching here. And Nikki, thank you so much.
Welcome.
Yeah, I have all kinds of thank yous here. Nikki, you can be reached. We saw your slide, but it was really, really short. So maybe you could just say how people can reach you.
Yeah, absolutely. So we have a website, www.franklinphysiotherapy.co.uk. We also have Instagram and Facebook pages. So Franklin Physiotherapy Limited, and our Instagram account is, I'm just going to check that I say the right handle for you guys now. It's always the way, isn't it? At Franklin Physiotherapy. So yeah, find us on social media. You can find us online. And if you need to ping an email with any questions, you can send that directly to me at Nikki, Nikki, at franklinphysiotherapy.co.uk. And I'm happy to answer more.
Don't worry if you didn't get any of that. I'm going to add all of these links in the comments for the recording.
Thanks, Tom.
Great. So thank you both, Tom and Nikki, and thank you everyone for watching us and for all your questions. And I wish you all a super great night and a lovely May Awareness Month to EDS and hypermobility. So good night for now. Bye-bye.